We were talking about pseudoprogression in the beginning. I think this is it happens not that often like we thought in the beginning. It's about 3 till 5% of our patients when we collected our data. Plus, when the decision is always important, if there's a progression, we should switch to chemotherapy. But when we do the combination then I think it's not that clinically relevant. And from my point of view, the pseudoprogression when happened in the beginning, but in the longer period, I never saw a pseudoprogression. In this situation, after half a year, when there's a progression, I think it's a real progression or not a pseudoprogression.
Yeah, no, that I completely agree with you. I think pseudoprogression, we kind of oversold it in lung cancer, but the issue that I wanted to get your opinion on is hyperprogression, which I think is real. I think it happens. I don't have a good number. I carry around the number of 5% maybe of patients have hyperprogression, which is kind of, we struggle with what the true definition of hyper or how to define it, but we all know that it's real in clinical practice. What are your thoughts on hyperprogression?
We had a poster on the ESMO about this fact that we can measure with some biomarkers CDL4 cells. I think there's a possibility to measure if there's a hyperprogression more relevant, so you can use that perhaps, but it's a clinical, very relevant issue because we have to know pseudoprogression or hyperprogression.
Right.
But in my clinic, sometimes those patients run away very fast and you cannot stop them, even what you're doing. So it's...
Yeah, no, I think we don't understand the mechanisms of resistance to immunotherapy agents. I think it's probably very different if you have a patient who's maybe been on immunotherapy for 18 months and then they progress. That's different, obviously, than the other end of the spectrum where you progress in the first 6 weeks. And so I don't know that we understand the biologic differences from those sorts of things. There is some data getting back to docetaxel ramucirumab. They did an unplanned retrospective analysis of how rapidly you progressed after first-line treatment, and there was some evidence in the very, if you transition to second-line therapy within 4 to 8 weeks, that there was activity of docetaxel ramucirumab in that population. Thoughts about that data?
I know better the nintedanib data in this Lung-1 trial, where we saw the same thing when the patients progressed in the first 6 months. The antiangiogenic drug worked much better. And I think for those patients who are fast progressors, I think they need ramucirumab or nintedanib in this situation.
Yeah, I think that's the take-home message, is that in the patients who progress quickly, that there's still an option that may benefit the patient, but it probably is the combination of docetaxel with an anti-angiogenic agent in that setting.
Although the one thing to consider is the hyperprogressors are more likely on single agent than chemo.
Right. Yeah.
Combos.
Yes.
And so if they progress on single agent, I think they should get a platinum doublet as opposed to going straight to
I
docetaxel.
I completely agree. Yeah, that's an excellent point. Suresh?
I just wanted to make the point that there's emerging data, for example, from the Yale group of the slow progressors, the later progressors, and it was a small publication, a small series of 26 patients in the JTO, which suggested that when you give them a local therapy on slow progression, many of them actually could continue on, even in long disease remissions or control rates, even with or without the same IO. So it's emerging data, but I'd be interested to see what the others think about slow progressors. Do you just abandon chemo? Or do you abandon IO and IO combinations? Or is there a group where you should actually think of local therapy and then proceed just like we do in the driver mutation patients?
Right, I mean, it follows the same paradigm. So I think that's something that certainly I consider in patients if they have either slow progression or a maybe solitary site or maybe 2 sites in which the downside of doing targeted radiotherapy is very small. I mean, it doesn't add much in the way of toxicity. So we've certainly done that and continued beyond that. I'm aware of the Yale experience, but what do others think of that? It's kind of, as you point out, it's something that we started in the EGFR ALK populations where we had a single site either in the brain or elsewhere, and you would radiate it and continue systemic therapy, thinking that most of your disease is controlled. However, these sites may, for whatever reason, be resistant to the treatment. Other thoughts about that?
I'm completely in line with you that we learned from the EGFR ALK ROS1 mutated patient that the strategy with PFS1 and 2 works. When we do a local treatment in a local progression, this clone pops up, and we try to to treat that clone. And I think we should use the same regimen, and we are doing already that for IO patients also. But it's only a small piece of the patients that really show that progression type.
Yeah, I mean, I'm sorry, go ahead.
Oh, I was going to say, you need to make sure they are progressing, because we've had instances where it looks like a patient's progressing even at 12, 18 months, and we've diagnosed granulomatous disease, we've diagnosed a new MET from a different tumor type. So if before you do that local therapy, I think it's important to biopsy to make sure that you're actually doing the right thing for the patient.
Which we don't always do.
No.
Right?
No.
Yeah, so I think that's a good
That's a good point.
point.